Yes. Hello, guys. My name is Dr. Khan Mohammed Zulfikar. I'm a fifth year medical student from Kharkiv National Medical University. And today, as part of the medical genetics subject, we are going to talk about a very, very important topic, which is beta thalassemia. And basically, it is an inherited blood disorder. So we have some basic points for discussion as for today. So we'll know about the overview of beta thalassemia, the differential diagnosis of beta thalassemia, the workup or diagnostics for beta thalassemia, treatment and management, and lastly, but not the least, which is the medication. Okay, so about the etiology of beta thalassemia. So usually beta thalassemia is an inherited as an autosomal recessive disorder. The defect can be a complete absence of the beta globin protein or a severely reduced synthesis of the beta globin protein, i.e. that's how you get the beta thalassemia. But in beta thalassemia major, i.e. which is also called a homozygous beta thalassemia, the production of the beta globin chain is severely impaired because both beta globin genes are mutated. The severe imbalance of the globin chain synthesis, alpha, which is greater than beta, results in ineffective erythropoiesis. What I mean by erythropoiesis is that giving rise to new red cells and this causes severe microcytic hypochromic anemia. And the excess unpaired alpha globin chains aggregate to form precipitates that damage red cell membranes, resulting in intravascular hemolysis, premature destruction of erythroid precursors that results in intramedullary death, ineffective erythropoiesis, and the profound anemia typically, which is associated with erythroid hyperplasia and extramedullary hematopoiesis. So we have intracellular fetal HP concentrations, we have the coinheritance of alpha thalassemia, and then we have the coexistence of a sickle cell trait. So these are basically the factors known to influence the clinical phenotype of thalassemia. We're coming back to the epidemiology, and we are going to take a reference point in some of the developed countries, or let's say the first world countries, like the United States. So the occurrence in the United States. Basically, the presentations are, the communication tools that catch the frequency of beta thalassemia, which varies widely. So depending on the ethnic minority, this disease is reported most commonly in the Mediterranean, African, and Southeast Asian populations, and can be used as demonstrations, lectures, speeches, reports, and more. It is mostly presented before an audience. About the international occurrence, okay, found commonly in the Mediterranean region, Africa, and Southeast Asia. And race-related demographics, which is very, very important, and it's said to affect a lot of ethnic minorities. Example, the Asian race, where people are usually affected with thalassemia. So how do we conduct a history and a physical examination for beta thalassemia? Patients usually have unusual findings. So in patients with beta thalassemia major, the physical findings are related to severe anemia. So we have ineffective erythropoiesis, and if you have ineffective erythropoiesis, that means that the red blood cells count, they go down. We have extramedullary hematopoiesis and iron overload, resulting from transfusion and increased iron absorption. So why does the iron get overloaded? Because you get the transfused blood over there, and then we don't have the main enzymes for transporting iron. And as a result, you have an increased iron absorption, and you have to take some iron supplements in order for that iron to be regulated. The skin may show pallor from anemia, jaundice, and from hyperbilirubinemia, and the skull and other bones may be deformed secondary to erythroid hyperplasia with intramedullary expansion, cortical bone thinning, and skin ulceration, which may be present on the extremities. This can also cause maxillary enlargement, overbites, malocclusion, and painful swelling of salivary glands, and a dry mouth may occur. Abdominal examination may reveal changes in the liver, in the gallbladder, spleen. So hepatomegaly is very, very significant for that. And patients who have received blood transfusion may have hepatomegaly or chronic hepatitis due to iron overload. The gallbladder may contain bilirubin stones formed as a result of the patient's lifelong hemolytic state. Usually on a long-term thalassemia might cause hemolytic jaundice, and that's the reason why we can have the bilirubin stones formed as a result of that. Okay, coming back to diagnostic considerations. So a major diagnostic consideration is to distinguish mild microcytic anemia due to beta thalassemia carrier state from microcytic anemia due to other causes. Iron studies, iron like transferrin, ferritin, are useful in excluding iron deficiency and the anemia of chronic disorders as the cause of the patient's anemia. We have the calculation of the Manster index, mean corpuscular volume per red cell count, which may be very, very helpful. Unstable HB levels and some types of red cell membrane disorders are other conditions to consider in the differential diagnosis of beta thalassemia. Coming back to the main focus point of beta thalassemia, we have alpha thalassemia, we have the anemia of the chronic disease and renal failure, we have the iron deficiency anemia, lead nephropathy, sideroblastic anemia. So what are the what are the considerations for thalassemia major, which is the beta thalassemia? So we have skeletal abnormalities in patients with long-standing beta thalassemia major, which include an expanded bone marrow space, resulting in thinning of the bone cortex. These changes are particularly dramatic in the skull, which may show the characteristic hair on end appearance. Guys, this is very, very important to note this. We have this thing called the characteristic of the hair on end appearance. Bone changes can also be observed in the long bones, vertebrae, and pelvis. The liver and biliary tract of patients with thalassemia major may show evidence of extramedullary hematopoiesis and also show damage secondary to iron overload, as we discussed previously in the pathogenesis of beta thalassemia. Heart is as well a major organ which is affected by iron overload and thus causing anemia. Cardiac dysfunction in patients with thalassemia major includes conduction system defects, decreased myocardial function, and resulting into a very critical stage known as fibrosis. Some patients can also develop pericarditis, and CMR, which means basically the MRI, is considered the criterion standard for measuring cardiac indices. Thalassemia minor, which is not like thalassemia major, usually presents as a mild asymptomatic microcytic anemia and is dedicated to routine blood tests in adults and in older children. These laboratory findings should be evaluated as indicated. Let's go for lab studies. The diagnosis of beta thalassemia minor usually is suggested by the presence of the following: mild isolated microcytic anemia, target cells on the peripheral blood smear, a normal red blood cell count. Lab studies, Haynes bodies, which are the main representations of the inclusions within the RBCs consisting of denaturated hemoglobin, may also be seen in the peripheral blood. Elevation of the hemoglobin A2 level demonstrated by electrophoresis or column chromatography confirms the diagnosis of beta thalassemia trait. The HbA2 level in these patients usually is approximately 4 to 6%. In rare cases of concurrent severe iron deficiency, an increased HbA2 level may not be observed. Free erythrocyte porphyrin (FEP) tests may be useful in situations in which the diagnosis of beta thalassemia minor is unclear. The FEP level is normal in patients with the beta thalassemia trait, but it is elevated in patients with iron deficiency or lead poisoning. So you can see how we can differentiate beta thalassemia and iron deficiency anemia in the in comparison with the differential diagnosis we have, as if you take the FEP test for beta thalassemia, it's usually normal. But if you see the FEP test in iron deficiency anemia, and if it's positive, that may be useful for the iron deficiency anemia, but not beta thalassemia. Another, we have other studies such as the genetic defects in the alpha globin chain, which can cause alpha thalassemia. But for beta thalassemia, you need to have a defect in the beta chain or both of them. That is the beta thalassemia or thalassemia major. We have iron studies, that means the iron, the transfer, and the ferritin, which are useful in excluding iron deficiency and anemia of chronic disorders as the cause of the patient's anemia. As a result, we discussed it before, that the level of iron increases during the transfusion in thalassemia. Okay, and the patients may require bone marrow examination to exclude certain other causes of microcytic anemia. So physicians must perform an iron stain, which is the Prussian blue stain, to diagnose sideroblastic anemia, which you can see significantly amount of ringed sideroblasts. Prenatal diagnosis, this is for the neonates. Prenatal diagnosis is possible through analysis of the DNA obtained via chorionic villi sampling at 8 to 10 weeks fetal gestation, or by amniocentesis at 14 to 20 weeks gestation. In most laboratories, the DNA is amplified using PCR, and then it is analyzed for the presence of the thalassemia mutation using the panel of oligonucleotide probes corresponding to non-thalassemia mutations. Since the genetic defects are quite variable, family genotyping usually must be completed for diagnostic linkage, aka which is the segregation analysis, and the anticipated availability of large-scale mutation screening by DNA chip technology, which is an extensive pedigree analysis, may be obviated. Physicians can perform fetal blood sampling for hemoglobin chain synthesis at 18 to 22 weeks of gestation, but this procedure is not as reliable as DNA analysis sampling methods. So the genetic therapy strategies are currently in the early stages of the development. So the therapeutic approach to the thalassemia varies between thalassemia minor and major. So let's just skip to thalassemia minor, which is treatment for patients with thalassemia major, and includes the following. So we have the long-term transfusion therapy, the erythroid maturation agents, iron chelation, splenectomy, allogenic hematopoietic transplantation, and other supportive measures, which include the folic acid replacement and monitoring for the development of complications such as pulmonary hypertension, osteoporosis. As we discussed before, we have bone thinning, bone fractures, spur dentation, heart failure, and anaplastic crisis with parvovirus B19 infection. Long-term transfusion therapy. The goal of long-term hypertransfusional support is to maintain the patient's hemoglobin level at 9 to 10 grams per deciliter, thus improving his or her sense of well-being while simultaneously suppressing enhanced erythropoiesis. This strategy treats the anemia and suppresses endogenous erythropoiesis so that extramedullary hematopoiesis and skeletal changes are suppressed. Patients receiving long-term transfusion therapy also require iron chelation. Why iron chelation? We need it because as the iron, it decreases, so it becomes an iron overload. Blood banking considerations for these patients include completely typing the erythrocytes for Rh and ABO antigens prior to the first transfusion. We move on to a long-term transfusion therapy. There was a study conducted of 116 patients who were, 51 males and 65 females with thalassemia major. Males were receiving more units of red blood cells per transfusion and had a higher annual transfusion volume, but with correction for weight, females were receiving a higher transfused volume per kilogram. So that's 225 versus 202 milliliters per kilogram in males. Erythropoietin EPO levels were higher in male, and the incidence of splenectomy was high in males as well. Well, you can relate it to that because males, they usually have a lot of hard work to do. So might be related to that, and other complex systems the males have. We have the diet and activity. So drinking tea may help to reduce iron absorption through the intestinal tract. Vitamin C, which is very, very important, may improve the iron excretion in patients receiving iron chelation, especially with deferoxamine. Deferoxamine is usually injected when you have thalassemia major. It's due to the iron overload, and it's like an antidote for iron, so it really helps for that. However, anecdotal reports suggest that large doses of vitamin C can cause fatal arrhythmias when administered without a concomitant infusion of deferoxamine. So the patient activity may be limited secondary to severe anemia. We have the gene therapy. Since the first successful gene therapy for thalassemia major in 2007, researchers have worked to improve the efficacy and safety of the procedures. And in this process, an autologous hematopoietic stem cells are harvested from the patient and then genetically modified with a lentiviral vector expressing a normal globin chain. Surgical treatment. So we have splenectomy. Physicians often use splenectomy to decrease transfusion requirements in patients with thalassemia major. Patients with thalassemia minor only rarely require splenectomy. Splenectomy is recommended when the calculated annual transfusion requirement is greater than 200 to 220 milliliters RBCs per kilogram. We have another one which is called the cholecystectomy. Patients with thalassemia minor may have bilirubin stone in their gallbladder, and if symptomatic, may require treatment. For thalassemia major, we can have cholecystectomy done as well. So it can be both minor and major. Investigational therapy. Emerging therapies include pharmacological agents that induce fetal hemoglobin injector inhibitors to reverse splenomegaly, hepcidin-related compounds to improve iron metabolism, gene therapy aimed at delivering the beta globin chain into the cells by a viral vector. And because the gene therapy, it's very, very important. We go to the gene therapy for beta thalassemia, which is being pursued by several research groups. In one case, report an adult patient with severe transfusion-dependent beta thalassemia, became transfusion independent for 21 months. So, and after 3 months after lentiviral beta globin gene transfer with peripheral blood hemoglobin being maintained at 9 to 10 gram per deciliter. So basically, this is me, Dr. Mohammed, with my cousin, Masuma. She is 19 years old now, as we talk 2021. She's quite sick and she suffers from beta thalassemia. The parents actually were carriers because they were first cousins, and they were married and the first cousins. And you can see how weak she is. And I'm just with the nurse over there, supervising, and just the nurse is explaining me how weak she is. It's quite a gruesome experience for me. So medication. The medical therapy for beta thalassemia primarily involves iron chelation. Each unit of transfused red blood cells contains approximately 200 milligrams of elemental iron. Additionally, anemia and ineffective erythropoiesis downregulates the synthesis of hepcidin. The following chelation agents are approved for use in the United States. So we have deferoxamine, which is IV administered, deferoperon, orally administered, deferoxyrox, orally administered, and approved for the treatment for chronic iron overload due to multiple blood transfusions and non-transfusion dependent thalassemia. We'll skip the study and skip the deferoperon, which is particularly effective for cardiac iron removal and is therefore recommended for use in patients with significant cardiac iron loading or iron-related cardiac disease. So we have a very important topic, which is the erythroid maturation agents. In November 2019, the first erythroid maturation agent was approved. And well, basically what happened is what happened was the adults with beta thalassemia who require regular red blood cell transfusions, they required this therapy, and it provided promising results. Actually, it really provided promising results. So we have the luspatercept, nadiazole, and the luspatercept AMT. I appreciate your attention throughout this presentation. This was Khan Mohammed Zulfikar. I hope you enjoyed, and please note that if you have any kind of questions, you can email me at ibrahim_khan7@yahoo.com. I'll be very, very grateful for that. But anyways, goodbye for now. Thank you.